We have Dr. Christopher Smyre, Director of Diversity, Equity, and Inclusion of Family and Community Medicine Department at SIU. Dr. Smyre will discuss the historical structures and socializations that create the disparity by one, disproportionately priming individuals from, oh my gosh, I'm sorry, I don't have lights. Okay, groups, and two, instilling legitimate, oh gosh, I can't see, sorry. Okay, mistrust in resources and services that would support them. And our third panelist, Dr. Abdi Tinwalla, President-elect for Illinois Psychiatric Society. Dr. Tinwalla will discuss social determinants of health in rural and remote communities. We will first, so each presenter or panelist will discuss their topics, and then we will have a great session for discussion of question and answers at the end. Dr. Rosenfield, would you please, I guess you're on.
Okay, thanks so much, and welcome. Nice to meet you all here. I am visiting from New York, and I am just a bit about my background. I've worked in schizophrenia research for several years at Columbia, and then I wanted to go out into the community and worked in public psychiatry and very interested in recovery-oriented care for people with serious mental illness. And now I'm at Mount Sinai Morningside in West as the training director and teaching about public psychiatry. And this is part of what we teach about. So I'm glad to share this with you today. Let me just get this set up. All right. So we're going to talk about just sort of to lay the groundwork a little bit about social determinants of health so that the other speakers will deepen that in exploring the healthcare disparities that are related. So I like to think about this. I got really into trees lately. I just read the Overstory this year, and I think there's so much to learn about from trees and their lives. So this slide gives you just sort of an introduction to this idea of on the left, a healthy forest has a diversity of trees. They actually communicate with one another above ground and below ground through this mycelial network. And they absorb the carbon dioxide from the air and store it down in their roots and provide oxygen for all of us to breathe. If you disrupt that environment through deforestation, cutting down trees, or introducing other contaminants, you will undermine the health of that community, and they will not only they'll lose their connections, that mycelial network. The trees are not as healthy. They aren't living as a community and supporting one another. And so I think this is a nice analogy for how we can think about the health of our communities. Now, one of the ways to really undermine a community and a family and a person is in the realm of adverse childhood experiences. And I'm sure many have heard of ACEs, and just wanted to introduce that as one sort of example of a social determinant. These different types of ACEs, from different forms of abuse, different forms of neglect, and different forms of household dysfunction, have been shown to have a powerful impact on an individual's upbringing and their outcomes in their lives. Has long-lasting impact. So there may be actual physical injury, fractures, traumatic brain injuries that stem from these ACEs. There are mental health outcomes, increased risks of depression, anxiety, suicide, PTSD, maternal health outcomes, pregnancy complications, risk of infectious diseases, risk of chronic disease. Also, these adverse childhood experiences can increase diabetes, cancer, lung disease, multiple chronic diseases, probably through some impact on the inflammatory system and the immune system. Risky behaviors, increased risk of drug abuse, and loss of opportunities, less likely to complete education, and there's impacts on occupation as well. And I'm not sure if you've seen this before, but this is sort of the risk for negative health outcomes increases as you have an increasing number of ACEs from 0 to the total number goes up to 10, but at 4 and above, we really have a significantly increased negative outcomes in those domains that I was just mentioning. Now, this concept of ACEs has been expanded to different realms, and this is one way of sort of getting further into the broader view on social determinants. But in the realm of ACEs, there's the household ACEs that we just talked about. These are individually felt. And then there are community ACEs. These are also what we often refer to as social determinants, but the idea of substandard schools, discrimination, historical trauma, lack of capital and mobility, structural racism, lack of jobs. These all have take a toll on the community, and that is also then reflected in the individual lives of patients, of people living in the community. And then, very importantly, people have started to talk about the role of the environment and the climate crisis and changing weather and storms, and these also have an impact, traumatizing individuals and communities. So this idea of social determinants of health has been around for really a long time. If you really go back to the idea that the social conditions in our society can impact people's health, from discovery of cholera and drinking water to just want to sort of a recognition of Paul Farmer's incredible work in Haiti and Rwanda, who just passed away, sadly, prematurely, did incredible work trying to look at how the community and society's infrastructure and access to basic needs, has a clear impact on health, and really contributed a lot to helping improve the health of those populations that he worked with. Social determinants of health have been described by this Healthy People 2030 initiative as the conditions in the environments where people work, where they're born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. And there are different ways that people have broken these down, but this is one sort of breakdown of different types of social determinants, from education access and quality, health access, healthcare access, the neighborhood and built environment. What is, how healthy are your buildings and your community? Is there violence in the community? Are there what kinds of resources are available? Just housing, affordable housing. The social community context, how is a huge important piece, and economic stability and ability to sort of invest your capital in housing and have a job and all these things. So this is a sort of breakdown of the different types of social determinants of health, and why are they important? So I've sort of been talking about this, but medical care is thought to just account for 10 to 20% of the modifiable contributors to healthy outcomes for a population. So there is a lot more that impacts health. Social determinants are thought to account for 30 to 55% of health outcomes, perhaps even up to 80%. And they certainly contribute to health disparities and inequities, which we'll hear more about. And I just share this example of Flint, Michigan, not I guess 300 miles away from you all, where clearly we saw how a decision, a governmental decision to save money and provide water supply to Flint, Michigan from the Flint River, which was polluted by toxic wastes over many years, instead of a treated plant in Detroit, led to the corrosion of the pipes and a huge spike in lead and Legionella and many other problems. And so it just, we're going to get to this idea of how social policy and governmental decisions can impact the health of folks that we take care of. So this is just a slide to show how these different parameters then, these are the examples of those different categories: economic stability, like employment, housing and parks, the quality of education, access to food, exposure to violence and trauma, healthcare access. These all lead downstream to health and well-being, and ultimately morbidity, mortality. And this is sort of the realm of social determinants of health, but we know that social determinants, these same social determinants also impact mental health. This, as I was sort of giving with the example of Flint, is these inequities are often driven by public policies and social norms. These aren't just like, okay, well, this is the way it is, and so let's try to treat this individual in front of us with this problem. No, we have to also think and look back to what are the underlying structures that cause these problems, so that we aren't just treating that outcome. And so going back to this, I think we want to think about the health of communities and think about all the different factors that go into maintaining that health, and what can we do to both on the individual level and also on the structural level. And this is just one example, going back to the example of the ACEs, of this was by the CDC, sort of an approach that includes both individual and sort of structural community interventions. So strengthening economic supports to families, not just saying, okay, I have a kid who's been traumatized, let me try to provide therapy to help them deal with their PTSD, or remove them from their family so that they can have care elsewhere. What if there were family-friendly work policies that reduce the risk of violence in a family because the parent is so stressed by lack of financial security, or public education campaigns and teaching people about bystander assistance, and using training men and boys as allies in prevention of violence in the home, early childhood home visitation, preschool enrichment, social and emotional learning to teach skills, mentoring programs. So you get an idea sort of what is possible on those different levels, and ultimately also advocacy for political change and investment in the resources of a community. I think Dr. Tinwalla is also going to talk about how insurance companies can help with that process. So I just want to leave you with an action item. I was asked to do that, and I think that's to ask you to think about one of your patients with negative social determinants, and set a goal for how you could advocate for them through both individual and structural interventions. What would be we are very well trained to provide those individual interventions, but what can we do to think about the larger systems that contribute to these problems, and whether it's through advocacy, whether it's through creating a program, whether it's through advocating through insurance companies to cover a broader range of care. So I will leave it at that, and thank you for your time.
Thank you, Dr. Rosenfield. That's riveting. I mean, great food for thought. So we will now turn to our second panelist, Dr. Christopher Smyre.
Thank you. Really enjoyed the talk, Dr. Rosenfield, and I think it's going to be really helpful with tying in to my talk. My name is Dr. Christopher Smyre. I am a family medicine physician by training at SIU, and I'm also over diversity, equity, inclusion for our department. And my talk is going to be focusing on really how we go from determinants to disparity. And while that may sound daunting, that is the reality of many people in America. And also, it does not have to continue to be that case, and that we actually are able to influence people's lived experiences. I want to start by thinking about how we define reality, because I think as physicians, we are privileged that we get to have final say, and sort of our word and assessments are taken as a standard, and that we can say someone no longer has the rights to make decisions for themselves or others, and that they can only regain those rights after sort of our approval. And so when we think about that, then it really makes us really wonder, what does it mean to be healthy? And more of a complicated question, when we think about mental health and sort of how are we defining normal, appropriate, inappropriate, and where does that standard even come from, and how that standard evolves over time. I think it's so important that we realize and be honest that the systems that we grew up in, that we interact with, they all influence our perspective and our outlook. And for better or worse, being that if we have a lot of negative systems at work, we may have a negative outlook in view. But on the positive side, that we can change those very systems, thus having a positive change of our outlook and perspective. And we can see how we have evolved and grown as a country, and still have work we can do both in our policies and practices as a nation, but also within healthcare. And I think when we talk about this, Dr. Roosevelt, it was in the slide, but we have to really think about sort of where these systems came from, how they were founded. And the reality is that all American systems, when we look through history, were sort of built off of racist ideology. And when I'm talking about racist ideology, what I mean is that the ideology at the time when most of these systems are being created is assumption about whiteness is right, and sort of normalizing everything from that presumption of white as the standard and default to then compare and talk about other situations and contexts. So a few systems, I just picked 4 for the purposes of this talk as an example. And these are some that you can see were also in Dr. Rosenfield's slides when he was talking about. But in thinking about land and ownership and even the banking system and sort of what that looks like, when we look at our history, we have to admit that European settlers came over, forced Native Americans off of their land, and then repositioned into small territories. We also look at the different practices that have gone on in many metropolitan areas and other rural areas with the banking system of redlining, where they were giving unfavorable interest rates and loans to marginalized communities. And then even when we think about sort of the value of property for those who were privileged to own property, and the way that we go through both gentrification, where we see people going in, buying up property and then raising the value and then exploiting that, right? And moving people who grew up there off of that, as well as the depreciation of land and value. And so when we think about back in the 50s, 60s, 70s, even, of how when you would see an African-American or someone from a marginalized group move to a community that was predominantly white, a lot of white people would leave that area and that community. The value would then therefore be seen and viewed as less. And so then your property sort of went down. And then at low property, it gets rebought. And so you see this cycle that sort of can happen. When we think about our education system, thinking about sort of how that funding is actually connected to property. And given what we just talked about with land and some of the biases built into how we own land and been able to gain ownership of land, that then further perpetuates this disparity within resources and financial allocation for school systems to support the needs of their learners. I think Jane Elliott's Brown Eye, Blue Eyes experiment is a great example of demonstrating that when discriminatory practices are at work, that you can see a direct decrease in a student's educational abilities. And also when we think about within the school system, the labeling of behavior that goes on, that there have been many studies that are documenting how African Americans tend to be viewed as more aggressive, and that narrative of sort of hyper aggression is something that is seen throughout history in many different systems and settings, but also the consequences that then come with that and sort of how we are labeling, defining, and how we are normalizing not only that individual, what those messages mean, but also those around the individual are crucial in thinking about what's being primed and sort of where we creating in the system. I think we can't overlook the law and legal system. I think over the past 2 to 3 years, there's been a great movement of awareness around police brutality that occurs with all the many deaths that have occurred and were sort of talked about and sort of led to a social awakening, for lack of a better phrase. And thinking about not only what that means for the family members who lose loved ones, what that means for the vicarious trauma to see life not valued as human life, and the disparity within the reactions and approaches that are taken by officers when the individual is Black versus white. We have to sort of think about sort of where did this come from? And when we look at history and sort of the creation of police, when we look at the civil rights movement, different behaviors that were done, we see a pattern that has continued. Another thing is the incarceration rate, and thinking about not only who gets prosecuted and tried, but also even the penalties for crimes. And so a classic example is when we look at the penalty for cocaine, that if you had 5 grams of crack cocaine, you were looking at a 5-year minimum sentence. However, if you had powder cocaine, you would have to have 500 to get the same sentencing. And the correlation between likelihood of African Americans more likely to have crack and white Americans more likely to have powder cocaine. And so just as Dr. Rosenfield talked about, these traumas, these adverse childhood events that we see occurring in our communities of color or in any marginalized group, we know will lead to negative mental health, negative overall health. But it's not only that, we even think about the jobs and sort of the opportunities for employment. I think this pandemic has really highlighted the variance of job opportunities, with certain jobs being able to work from home, the benefits and security that one could have versus others who had to be continually going to work and taking on the risk of exposure, especially early on, we didn't really know as much as we did about the COVID virus. Also at work, there's microaggression that goes on all the time. And we know that microaggression does have a psychological impact on individuals in the group. And the final thing of thinking about systems, especially within jobs, is what's commonly called the diversity innovation paradox, in which that we know diversity leads to innovation. And therefore, you would think that companies would choose to continue to want to be diverse so they can innovate and grow. But when you look at companies, you rarely see marginalized or minoritized individuals that are creating that diversity for the innovation, moving up into leadership roles and sort of growing. And this was actually done even looking at within the sciences. And they did a study looking at the PhD student thesis from white students versus Black and brown students, and what they found, or students from marginalized and underrepresented categories. And what they found was those students in the latter were more likely to have more innovative projects, a higher impact as far as of scholarly skill. But when they looked at sort of what that was being received by the community, it was less appreciated, less acknowledged and talked about. And thus they sort of highlight that as a reason why you don't see as many marginalized individuals going into academia potentially. And when we think about systems, healthcare as another system is not absolved or separate from this. And we have to be able to own our own history as healthcare professionals and as physicians, and being able to really talk about how are we going to now disrupt it. And so drapetomania was a psychiatric condition that was named by Dr. Cartwright, in which it basically said that slaves who wanted to run away were sort of suffering from this delusion, and that the cure for it was to whip them, beat them, cut their toes, they weren't able to run. And that one of the causing factors of it was slave owners that were too friendly with the slaves. And so this sort of biased view and outlook sort of getting incorporated within healthcare and diagnosis and labeling is something that we have to acknowledge as a part of our history. because other people are aware of it and talk about this. Another one is sort of thinking about what the face of schizophrenia looked like. And so prior to the 50s, schizophrenia was more so known for its neurosis and being docile. And so it was more so seen as like, you know, your housewives. And this is sort of who we thought of when we thought of schizophrenia and who was most likely to be diagnosed. However, after the 60s, when aggression became part of the descriptors for it, we actually saw more African Americans being diagnosed as schizophrenia. You can see sort of the advertising marketing in the image on the right. And not only that, but also the sort of continued weaponization that could occur, such that the picture of the building in the bottom left corner is Ina State Hospital, in which many African Americans were institutionalized for schizophrenia due to beliefs in civil rights and the civil rights movement. And so Dr. Metzel writes a book where he talks about that phenomenon and the history around that. And that's so important for us to think about because these are histories that people have experienced, have been passed on. And like I opened up with sharing how the power to define someone's reality and take away someone's right to even comment and speak on what they want to do and don't want to do is something that we cannot take lightly, and also is a legitimate fear that people have and concern if we're going to talk about these labels. And so what we find then is there's a system that penalizes with the labels that it gives, the hyper-aggressiveness that's attributed, the labeling of sort of white being right and minimizing anything else, right? That then leads to our own personal biases and thoughts regarding these labels and the ones doing the labeling, right? From the lived experiences we have, right? And so we may be hesitant and resistant to mental health diagnosis because of fears or because of things we've seen. And then with all of that, now create a situation where there is legitimate historical informed resistance and hesitancy of accepting certain labels and wondering, is this a perpetuation of someone that's not from my own culture defining me as just being different and saying that different is a problem, right? And what makes it so problematic is that most of our systems are built where you have to have a label to then qualify for services, supports, benefits. Granted, the caveat is also that you have the funding and resources to provide the services, support, and benefits. But what we then do without acknowledging this is sort of we prime people who are legitimately and rationally appropriate saying skeptical because of past harm that's happened to people who look like them or family members or they themselves. And then we say, unless we have these labels, then you're not able to get the services that can come from that. And so with that leading to then a gap in care and people missing out on appropriate services, what we can do to really address this problem is really to engage in cultural humility. And when I say cultural humility, it's being able to, one, appreciate the difference and acknowledge the differences that exist, to engage in respective curiosity around trying to understand how they themselves see their identity, and see the ways that their culture is influencing and the ways they want to be engaged around their culture. And then also then moving to walk together around shared values and interests that can come and sort of how it may be in alignment or not in alignment with their own cultural norms. We also have to be acknowledging the systems, the issues, and supporting people to actively navigate the current systems as they are. It's so helpful for people to be affirmed and say, I can understand, it's very reasonable to have some concerns here, and you're not the only one. Our own systems are already biased around mental health in particular, such that many people are scared to acknowledge their own mental health concerns or worry about potentially being judged by it. And if we can't acknowledge the biases that systems have regarding mental health and talk about that openly and honestly, then how can we really engage individuals who may have those same concerns and really see them as trusting us? And the final thing is really understanding that we have to change the systems, all systems, because they're all interconnected. They're all influencing one another. You know, the better your education, the more likely you are to be able to get a better paying job. The better you're getting a paying job, the more likely you're able to buy property. You can buy property and then create generational wealth and pass it on. But if you're having any breakdown in those systems, then you're going to have problems that then perpetuate and sort of allow certain individuals to be further harmed and others to be able to move forward. And I think this is the purpose that we all come together and wanted to help our patients to really work together to change these systems so that we can all grow and that everyone can get the services and support that they need to be their best, healthiest self. Thank you.
Thank you, Dr. Smyre. And I apologize for mispronouncing. I was driving in ICE, as I mentioned, so I have one eye on the steering wheel and one eye on my phone, but I've made it safely to my final destination. That was really thought-provoking, so thank you for that. And our last panelist, Dr. Abdi Tinwalla, our president-elect for Illinois Psychiatric Society.
Thank you. I'm sorry. Can you guys hear me? Hello?
Yes,
Yes.
we can hear you.
Sorry about that, guys. I was having problem getting off mute. So after two excellent presentation, thank you so much for participating, guys. I appreciate it, Dr. Rosenfield and Dr. Smyre. My name is Abdi Tinwalla. I'm a forensic psychiatrist. I'll tell you a little bit about my background because I think it's important in terms of the kind of work that I do right now and the kind of experience I've got working in rural and remote areas. I'm a forensic psychiatrist. I have been the chief of psychiatry for a correctional healthcare company for about 10 years. And as most of you guys know, the correctional healthcare companies are located in very remote areas. They are not, all these prison systems are not going to be in your urban areas. They are in outlying areas of Illinois. A part of my job also involves working with sex offenders, and there is a sex offender facility in the middle of central Illinois somewhere in a small town called Rushville. It's a town of about 2,000 people, and I spend the majority of my 10 years living 3 days a week over there and working with the community over there. I also provide treatment to the sex offenders in the community. And so part of that role of mine takes me around Illinois, wherever some of these violent sex offenders are being housed and taking care of them. So I have that experience. And then right now, currently I work with the health plans, a major insurance company. And so of course, part of that involves working with rural and remote communities to make sure that our members are getting appropriate healthcare. There is a lot of talk about social determinants of health and how we can partner with providers to help our members get the appropriate care that they need. So just to give you a background to kind of, set the ground of where I'm coming from. Let me go to the next slide. So as I think Dr. Rosenfield had mentioned, about 20% of our health outcome is actually determined by the healthcare that we get, but about 30% of it is by our health behaviors in terms of smoking, diet, exercise, drug use, and sexual activity. 10% of it is from our physical environment, and 40% of our health is actually determined by the social economic factors that Dr. Rosenfield also mentioned, and that I'll be going in some details. I think this is a similar slide to what Dr. Rosenfield had put up, where we talk about the different social determinants of health. In terms of economic stability, we have neighborhood and physical environment, education, food, community and social contacts, and then finally the healthcare system. So in the interest of time, I'm not going to go into a detail of all of them. I could spend probably 2 or 3 hours doing this presentation, as I told Christian earlier today. but I will try to limit it to some broad topics, and there are a lot of information on my slides. So if somebody wants my slide set, or if they want more information, they can reach out to me. So let's talk about healthcare access and quality. What do we have under healthcare access and quality? We have behavioral health awareness and literacy. We have integration of behavioral and physical health. The use of telehealth and the availability of broadband in the rural areas, and finally, transportation. Again, just to kind of put this in perspective, I'm trying to focus more on the rural and remote areas of Illinois, but of course, some of these will also apply to the urban areas also. In terms of behavioral health and literacy, Dr. Rosenfield also, and I think Dr. Smyre also talked about how early childhood adversities impact our behavioral health outcomes. So we need to have interventions that are focusing on increasing the behavioral health literacy, such as recognizing the symptoms of mental illness, understanding the treatment options, having a positive emotional health, decreasing the negative attitudes and the stigma that is associated with mental health, and also increase help-seeking behaviors. Also, integration of mental health awareness programs into existing social infrastructures, such as school, churches, and community organizations. In terms of integration of behavioral and physical health, I mean, this is the buzzword right now in the community. We all are looking at integrated behavioral health right now. And why is that becoming more and more relevant nowadays is because of the shortage of behavioral health providers. And we know that most of our members or our patients or our population in the rural health depend on Medicaid for their health insurance. And we know that Medicaid is not, the Medicaid rates are not really good enough. I guess they are not competitive, and not all providers in the areas accept Medicaid. So there is some benefit of integrating behavioral health and physical health together, especially in the primary care setting, because most of our members in the remote areas actually get their behavioral health services through their primary care providers. And SAMHSA has actually set out information on 3 frameworks for integrated care, which includes the collaborative care model, the co-located care model, and finally, the fully integrated care model. And also there are several federal initiatives out there right now, which have helped to set up the federal qualified health centers, the rural health clinics, and also the certified community behavioral health clinics, where some of our patients and members can actually get treatment in the rural areas. Talking a little bit about access of the use of telehealth. As we know, COVID has kind of changed the landscape. It has allowed and expanded the use of telehealth across the country. And so, you know, more and more members and patients, I keep calling them members because they are members to me, but I understand they also are patients. I think expanding the telehealth has helped us expand access and quality of care. However, we know that in some of our rural areas, broadband access is almost limited to non-existence. However, in those areas where there is the availability of broadband and telehealth, it can assist with integrated and the collaborative care model. For those who are interested, APA actually has developed a whole telepsychiatry toolkit, which gives a lot of information regarding insurance requirements, regarding licensure, etc. What have we learned from our experience with telehealth during COVID? I think the providers and individuals are liking it. I think it allows the families to be involved in the appointments since everybody's available. And also right now with the federal rules being relaxed in terms of the licensure and who can provide them, I think more and more telepsychiatry services are being utilized. And more health plans and insurance programs are now covering telehealth, including the use of voice-only visits. So which is, you know, sometimes very beneficial for those members who don't have access to broadband. The next one is transportation. I think transportation is big because in the rural areas, a lot of people don't have cars and there's no public transportation. It's difficult to get around. A lot of our patients miss their appointments because they don't have transportation to get to the appointments. So what happens to those members? Unfortunately, they end up in ER or they start using the emergency transport services for their routine care. What can we do to solve for this, right? There are mobile treatment services centers available so that you can reach the members in their own community, allowing the providers to actually cross straight lines and increase the availability and accessibility to our members, certifying some of the members to become secure transport drivers in the local community, and the use of telepsych or telehealth services wherever available kind of helps to bridge the gap of transportation as a social determinant of health. The next, we'll talk a little bit about economic stability. And what I've done is I've actually included housing instability and food insecurity under economic stability. I think to me, they all go hand in hand. This is the busy slide, but basically what it talks about is employment. If people are employed, they have financial stability, they will have a health insurance. However, if they're working in harmful work conditions, it can include psychosocial stressors that we talked about, which can have negative health outcomes, both physical and behavioral health. Unemployment can also have negative physical and behavioral health outcomes and leading to unhealthy behaviors. I think Dr. Rosenfield talked about education and racial and ethnic disparity, which exist in workforce. And in terms of getting help for our members, vocational training, job assistance, and increasing job opportunities in rural areas. As I was mentioning earlier, my job in the treatment of sex offenders, I go down to these facilities in the middle of Illinois in a town of 2,000 people. But when they actually build the facility, it allowed opportunity for almost 2,000 staff members to come in and work as either therapists, as security aides, and other staff personnel in the facility. So that was a good opportunity for people to get employment in the rural areas. Access to higher education. Again, this can be a big social determinants of health. Dr. Rosenfield also touched on this a little bit. Not having access to get good education can then impact their ability to get a good job, which can then lead to further financial insecurities. Food insecurities, this is also pretty big. I've actually, in my last couple of years of experience, I've traveled extensively across Illinois. I was down in Southern Illinois in a small town called Cairo. And I don't know if anybody has been there, but it's a really small town. It was lunchtime. I remember I was trying to find a place to eat and there was nothing there. I had to actually go down to a convenience store and buy some frozen food from there, heat it in the microwave and had that. So that to me was an eye-opener when they have no supermarkets, they have no restaurants, they have no, even fast food was not available in that town. So to me, I think it was big that we really need to do something. And especially coming from a health plan perspective, there was so much we could do to assist the local providers in trying to help them with their food insecurities. In terms of housing stability, this is again what we see from the health plan side, from the insurance side, we see a lot. Several of our members are on the streets. They don't have safe and secure housing. They get taken advantage of on the streets. They are robbed. The medications are stolen. They end up coming back into the hospital. This is a constant cycle that we have seen. And so I know that a couple of health plans such as United and Anthem have worked to increase housing services for our members. Housing subsidies is also offered by federal government to help them with assistance to pay their rent. However, we know there's a long waiting list and the funds are not sufficient for everybody who qualify. Finally, coming to the social and community contacts. We know that in the rural areas, the small closely knit community can both have a positive influence on them, can also serve as a barrier to healthcare because there's lack of anonymity and the stigma of mental illness can affect their ability to seek psychiatric care in small communities. However, there is a huge role for faith-based and community-based organizations to play in this and for community partnership. In fact, IPS is, we are in the process of working with Representative West from Rockford to actually partner with him and his group to provide faith-based education in churches across rural Illinois to educate the congregation and the members regarding mental illness, the symptoms, and the treatment available to them. And also in terms of the rural population, which is diverse, there is LGBT population in there, which are also disadvantaged at seeking mental health treatment. You have the African Americans, the American Indians, and the Alaskan Natives who also have difficulty in getting the treatment, appropriate treatment. In terms of faith-based, I think I mentioned this, 25% of people in the US reach out to their religious congregation for first mental health support. 31% of them receive some form of mental health programming from their congregation to help support people with mental illness. However, 71% of the spiritual leaders actually report lacking the training and skill to recognize mental illness. So what is available in terms of the resources for communities of faith? In 2018, APA published the Mental Health, a Guide for Faith Leaders. We also have the National Association of State Mental Health Program Directors, which published Early Serious Mental Health Guide for Faith Communities. There are others, I'm not going to read through all of them, but NAMI also has, it sponsors a NAMI FaithNet, which has resources for the communities of faith in terms of information regarding mental illness. How does community partnership help? They can help by having aging in place programs, by having meal delivery services, food pantries, right service programs, and recreation centers for our members. I think we briefly touched upon this. We have immigrant population also nowadays rising in some of our rural communities. These immigrant populations have their own challenges in terms of culture, in terms of the trauma that they may have experienced, in terms of the cultural biases that they may have, in terms of the language barrier they have in getting the treatment. So I think it is important to be mindful of the immigrants and the cultural diversity that we have in some of our rural population. What do we have in terms of resources? There are a lot of resources. SAMHSA has some resources available. There are No Longer Alone is another resource manual for rural sexual minority youth. There are, again, I'm not going to read through all of them. It's available. Finally, the last couple of slides, I do want to spend a few minutes on financing. We have Medicaid available, where people can use the Medicaid dollars to finance some of it. State and local government. Private health insurance can, sometimes health plans can help finance a lot of those. And one more, grant fundings, of course. And this is my reference, and thank you very much. I'm sorry, I had to be quick. I know there were a lot of slides, but I can provide the slide sets to people if they're interested.
Wow, thank you, Dr. Tinwalla. That was excellent. And I want to thank all of our panelists for an excellent job and very thoughtful presentations. Thank you all. Thank you, Dr. Smyre. I've been practicing that in my mind now, Dr. Rosenfield and Dr. Tinwalla. So now we're going to take questions because we had such a stimulating panelists here, but I feel like, I always love action. So those that know me love it, know that I love to